I was in this really unique space of being 19, so I'm over the 18 cutoff of peds, but diagnosed with a Ewing sarcoma. But I was an adult. I was able and supposed to be making my own decisions, but treated in a pediatric setting. And not everybody in that setting is expecting to talk to someone who is educated and understands what's going on. It wasn't always clear that people knew how to talk to me or how to interact with me.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Alec Kupelian, who is both a cancer survivor and the Program Development Manager at Teen Cancer America in Los Angeles, California. We will be discussing advocacy for adolescent and young adult patients with cancer and his own cancer journey. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Alec.
Thank you so much for having me.
So let's start with the beginning and then start with your story. So as an adolescent young adult, or AYA is the abbreviation we commonly use, as an AYA cancer survivor yourself, you clearly directly represent the topic we're discussing today. I was hoping that maybe you could just take us through your journey of your cancer diagnosis and treatment, kind of unfold that for us of how that occurred and what your journey was through that.
Absolutely. And happy to be here representing, of course, like every other experience, AYA cancer is not a monolith. So I can only share to my experience and those that I've spoken to directly. But I was 19 when I was diagnosed. I was a freshman in college. I've just kind of stepped out on my own. I was a college athlete and I pulled my groin. It never got better, never got better, never got better. I was still young enough to know everything. And I was like, after the season, I'll get checked out. Symptoms got worse and worse. I lost use of my left leg. And I was going to university about an hour and a half from my parents' house. And so I went back actually to take a friend to prom. And my dad, who is luckily for me an oncologist, I really picked my parents well. He saw me changing and he was like, oh, that's not okay. I clearly had deformity. My left leg had atrophied down to the bone. And so Saturday was prom. I didn't even have a change of clothes because I was just going to come back the next day to college. And Sunday, we went to the ER. I got an MRI. Monday, I got my biopsy. Tuesday, I moved out of college. And then in the afternoon, went and got my port placed. And by Wednesday, I'd started chemo. It was a quick timeline. I did about 11 months of chemo, 6 weeks of radiation. We didn't end up doing surgery. I joke a lot of the times that cancer was actually one of the best years of my life. And that's not because it was good necessarily. It's because that next year after cancer was probably the worst year of my life. And that drop off into that early survivorship was a really brutal experience for me and from talking to other cancer survivors for them as well.
Absolutely. That's something that I'm sure we'll get to on today's discussion. So let's talk a little bit about, maybe the early phase of that and when you were diagnosed in that AYA population. What do you remember or recall of some of the challenges that you faced that maybe other age groups might not experience as often or in the same way?
I was in this really unique space of being 19. So I'm over the 18 cutoff of peds, but diagnosed with a Ewing sarcoma. So I had about a football-sized tumor in my left hip that was sitting on the nerves that ran down my leg. But I was an adult. I was able and supposed to be making my own decisions, but treated in a pediatric setting. And not everybody in that setting is expecting to talk to someone who is educated and understands what's going on. I may not have spent a lot of time in a hospital, although with my dad, of course, we were very educated, but I was aware of what was going on. And to have clinicians that talked to my parents rather than to me, not that there isn't a place talking to my parents, absolutely. And where I was at, I was on oxycodone, OxyContin, gabapentin, and a morphine pump. Like I wasn't super all there right at the start. But it was one of those moments that it wasn't always clear that people knew how to talk to me or how to interact with me. Not to mention that I was having specific age-related issues as well. Fertility is a huge concern for this 15 to 39 age range. The average age in pediatric oncology is about 5 years old, and in adult oncology, it's about 65 years old. Fertility looks very different for those age ranges, right?
Absolutely.
But this 15 to 39 age range, if you're 15 years old and someone's like, right now, you have to decide if you want to start cancer treatment right away, or, especially if you're biologically sexed female, wait a few weeks, spend a few $1,000s to get your fertility just in case you want to have a kid sometime in the future.
That's heavy.
That's a crazy thing to ask. There's other concerns. I was 19. This is the first time I've kind of stepped out from my parents' house. I'm gaining my own independence. And all of a sudden, I'm more dependent than I was in college on my parents. I talked about being on that morphine pump. I couldn't walk. I could barely move. I was so tired and nauseous from chemo. My parents did everything for me. My mom was sleeping in my room every night because she was also scared. And I didn't have the language yet. I didn't have the emotional understanding of myself yet to say, I actually need a little bit of that independence back. And that identity forming time, 15 to 39, think about yourself at 15 and who you were versus 18 versus 22, right? 25, 30, 35. These are people who are at the beginning of knowing themselves and who they want to be and defining their school, their relationships. What does sex look like? If mine was in my hip. So are things that are happening, is that because I don't know what sex is? Is that because I'm inexperienced? Is this because it's cancer? And if you're a cancer patient, every pain, every issue, you're immediately like, oh, this is cancer again. How do we contend with all those things? And I think that's one of those big conversations that make it really specific to these AYAs. Not to mention, if you're in that older age range, you may have young kids of your own. AYAs are the least insured population, and they're the most likely to be non-adherent to their treatment. They have so many things in their life. Like, I have spoken to the father of 2 young girls who has to decide if he can afford cancer treatment or putting food on the table. What a decision that is.
Well, I think you've brought up, obviously some great points, but what struck me most is kind of your first comment of just recognizing how truly in the middle your experience was of having what is classically more of a pediatric type of cancer, but you being in that age group that puts you over that threshold. My practice has been based in adult oncology. And so you bring up a great point that of just the mentality of how you speak to and interact with a patient in this AYA group, depending again, where they fall in that continuum, needs to dramatically change based on just like the experience and the maturity of who you're working with. I can't imagine a more complex environment of you being 19, having to rely on your parents, just being newly kind of out of the nest, if you will. And so I think from the clinician's perspective, what a challenging thing to also balance of trying to get the right information to the right people. But I think you bring up that great point of that we have to stay focused on who our patient is and what their needs are and kind of cater to what they bring to their diagnosis and what their preferences are. So Alec, while you were in treatment, what do you remember about the nurses and how they were involved in your care?
I was treated inpatient. So I was in the hospital for about a week at a time, every other week for almost a year. And really what that means is I talked to my doctors once a day and I spent all day with my nurses. They were part of my everyday care team and I received the majority of my active care from them. And when I had questions, whether it was about life, certainly, but about my treatment, about my cancer, about my side effects, it was mostly the nurses that I went to. And the more that I talk to patients, and I work at Teen Cancer America now, so I have been here for the last 5 or so years, I talk to a lot of clinicians and a lot of young adult cancer survivors. And the more that I hear other people's stories, the more clear it is to me that you never know who a patient is going to disclose information to. A lot of those symptoms or side effects or secondary issues that come about from cancer, which complicate every part of your life, it may not come to the doctor. I was most comfortable with my nurses because I spent time with them. And I will give a huge shout out to my nurses who were so wonderful and truly became not just friends, but family during that year. I shared issues that I was having with my nurses that I never told my doctors. And that's a pretty common experience. I'll say, especially in that AYA age range, you just don't know who's going to say what. When I was in my early survivorship and I was compensating for the fact that I thought I was going to go back to normal life and normal life didn't look the same. And all of a sudden I'm depressed and I'm blacking out from alcohol 3 or 4 nights a week. And I have my first suicide attempt. I'm like, I'm not okay. And I didn't tell my doctor. I asked a nurse to help me get set up with a therapist. And so this concept of like, look, it is not your responsibility as nurses to deal with everything. The reality is that healthcare is wildly understaffed right now, nursing especially. That is nothing to say like nurses are overburdened with the work that they are responsible for doing. There's high patient volumes and a plethora of responsibilities. And that's just patient care. Not to mention you all have to live your own human lives and be normal people and learn along the way. There's admin responsibilities. There's notes to take. It is okay to tell a patient, hey, that's a lot. And I am happy to be a support system. And I don't have the answer. Let me talk to someone who is more knowledgeable about this, who can get you the right information. I'm not saying that you as nurses have to be experts in sexual health and mental health and suicide prevention and awareness and also disease and like that's too much for any one person to have. It is helpful as a patient, and I'm giving you permission now, all of the nurses who are listening to this, to tell a patient, I don't know. And that's not breaking their confidence in your care. On the contrary, it tells me as the patient that you're not going to make stuff up just because I asked. It tells me that the stuff that you have shared and are confident in is stuff that you do know, and I can trust that. So please, please always be honest with your patients, be upfront with your patients, and be ready for them to disclose something because it can be really scary.
As nurses, we do know that healthcare is a team sport. None of us can do it by ourselves, not physicians, not nurses, not our social workers, dietary. I mean, it's just a whole team that is needed at different frequencies and at different depth of care, depending on where you might be through your care continuum. But as you said, I think one of the best signs of a clinician is being humble and knowing what your limits are and being able to say that I don't have the answer, but I know who can help us, or I know where we should go next to try to find that answer. So I think if you asked any nurse, they would say that we absolutely want to be that person that you confide in or that you ask the hard questions to. I think that especially in oncology, but I'm sure in any specialty, that's what we sign up for. And we are okay with that. But as you said, we can't necessarily shoulder all of those requests ourselves, but being that sort of traffic controller of figuring out, okay, well, it's not me. Who is it? How do I get them in touch? How do I create that referral? How do I set that up and follow it through to make sure that that connection is made? That is absolutely what we as nurses want to be there to help with.
And to have those systems in place at your hospital to help support you, the nurses, in that. Like, you shouldn't be responsible for scheduling that appointment and maybe not even doing that follow-up. But it is good because you all build a relationship with the patients too. It's not like these are people you don't care about and you've just like are shuttling them through. No, like these are real people. And I remember there was this one night, it's late at night, and I'm talking to one of my nurses who's one of my friends, and she makes an offhand comment of like, and you know, like, that's why you don't have sex right after chemo. And I was like, oh no, I'm sorry, what? Oh no, we need to go back real quick and say, I'm sorry, what? And it's that moment where that nurse is like, oh, because I was talking to you as a real person, and we were connecting as human beings, that we were able to have this moment that I, now the patient, am getting the information that I need so that my partner isn't having yeast infection after yeast infection because I'm slowly poisoning them from the inside. And that's maybe too much detail, but that's to say, like, you really don't know what's going to matter to a patient.
So let's talk a little bit more about that, kind of on the topic of education. What do you remember of the type of education that nurses provided and kind of specific to what is important for or uniquely important for the AYA age group?
A lot of it, I will say, is similar to every other age range, right? Like your medication side effects is something that's really important for patients to know. An expectation of what's going to come is really important. And it's just treating that patient like that person, like we were talking about earlier. If you have a 24-year-old patient, but you're in peds, tell that patient, hey, this is going to be tough. You know, your doxorubicin is going to make you throw up all the time and you may sweat red and it's going to look like you're bleeding from somewhere in your body and you can't find a wound. just be aware that those things might happen. So a lot of the content isn't going to be different, but it's the way that we talk to that patient that is. Also recognizing that there are going to be age-specific needs for this patient. If this patient is in peds, your 24-year-old patient maybe doesn't need a teddy bear and finger painting. And if they're in the adult side, recognize that they're pretty healthcare naive. They may not know how the healthcare system works the same way your 70 or 80-year-old has had experience in the hospital before. It's new to them. But things like fertility, sexual health, psychosocial support. If there's a support group, that patient wants to connect to other people, and they may not feel like they're connecting to the 60 and 70-year-olds that are also in that support group. These are patients that are going to have decades of life after their treatment is hopefully concluded and they're doing all right. These are patients that are still in their identity forming, they're in education or early occupation, and they may need financial support. And what does that mean? What is the social worker that can get them access to those resources? Who are the people in the hospital that can help them? And who are the advocacy organizations outside the hospital that can provide some of that support as well? There's so many different layers of complication that cancer places on a patient. And being a young adult, like really put yourselves in that position of thinking about yourself at 15 and what would it mean to be so unsure about yourself and all of a sudden you're bald or have a huge scar and your friends don't know how to talk to you anymore. What does it mean to be 20 and you're trying to figure out your career and all of a sudden you have cancer and you don't know if you're going to be allowed to have a career because all the work you're going to do to get there is going to be ripped away by some disease at some point anyway. Like these are the thoughts that we all have as AYA cancer survivors all the time. If you're 24 trying to date and you know you're sterile, and how do you bring that up? At what time do you bring that up in dating? Is it in your Tinder conversation? And also I had cancer and we'll never have kids if we get married. And does that scare that person away? But is it misleading? Like, I don't know. It sucks.
Right. These are not surprising things to hear, but again, just bringing them up and talking about them out loud, I think just really shines a different light on them for nurses to consider. And we're seeing, unfortunately, we are seeing more patients being diagnosed within this AYA age group. Early in their 20s, 30s, even in their teens now, we're seeing these diagnoses that typically have not been associated with younger people. We are seeing them now. And so while some of our listeners might think, oh, well, I work firmly in the adult space, this is not something that will come across. It is. And it will unfortunately be more common. And so I love just the candid nature that you're sharing with us of just kind of what you recall from your experiences. But along those lines, what are some things, and you've given some examples, but what would be some recommendations just based on your experiences that you think nurses and other members of the healthcare team can do to help improve the experience for AYA patients with cancer?
I'll keep coming back to it and I'll keep coming back to it, but it is that communication piece and it's how you talk to those patients. And it's taking a little bit of a break to say, you're a real person. I'm a real person. Let's connect. And I think there's so much learning to be had. And I encourage every nurse to take one moment, and that's with any of your patients, but to just to have that real moment to say, hey, how are you? And then when they say, I'm good and you, stop and say, hey, but how are you really? And I think that moment of saying like, I don't have all the answers, but I just want to be there for you goes a long way. AYAs are the least adherent to treatment. And like you're saying, they're getting younger. I think it's something like 40% of all colorectal patients now are under 50. Cancers are getting younger and younger. And so this is going to happen more and more. There's so much learning to be had. There's so many ways to be proactive. I think more than anything is just treating them like that person they want to be, making that connection. These are people who aren't always confident in what they're doing. And healthcare more than anything, like I said, right, this is the least adherent population to treatment. And research is showing that it's not because they don't understand, it's because they are, quote, tired of having cancer. And that's it. That's it. So what is it in our day that can make a patient adhere better? And really it's just, hey, we are not treating a cancer. We are treating a person with cancer.
I really love how you emphasize just asking them how they're doing, starting out that encounter. It could be the first time you meet them, or it could be the 50th time you've seen them in clinic or infusion or inpatient, depending on where their treatment as you mentioned earlier, that sets the foundation for creating that trust in that relationship that's deeper than just a clinician and a patient, but that familiarity, which is, again, I would say that most oncology nurses would say that's why they do what they do, because they do see patients over and over and over again. And we're able to have the honor of taking them through that care journey and creating those relationships that sustain, as you said, even outside of the clinic. That's what brings meaning to our work as well. And so just opening that door and setting that foundation for patients who might feel a little nervous to ask those hard questions, or maybe they're slightly uncomfortable or embarrassing questions. But the earlier we can create that connection and let them know that they can have those conversations with us, with anyone in their healthcare team. But again, as you mentioned, a lot of times they're seeing most of the nurses, just given the amount of time that we have dedicated to their direct care. And so trying to set that foundation of, you might not be ready to ask it now, but I want you to know that when you're ready, you can ask me and you can share that with me, and I will give you an honest answer, whether it's I have the information or I'm going to find out who can help us. But I think that's so important. And so I really appreciate you bringing that up.
If that one, how are you, means that one of your patients feels comfortable to tell you they're suicidal, that patient could have been me. If you get to be that nurse, how heavy is it for you? But how honored to be the person that they felt safest to trust with their life. And I think that's one person saved, not supported, not helped along in their healthcare journey. Like, no, really and truly, like that's a life saved. Again, it is not your job to be everything, but you can be something. And I love that.
Well, let's transition now to your work, your current role at Teen Cancer America, which is an AYA advocacy group. What brought you to work for this organization?
Teen Cancer America came into my hospital room while I was being treated to do a little news piece to say AYA isn't the same as every other patient. And since that, and I will say that was 10 years ago this month, I was diagnosed 10 years ago in May. And I've been advocating with them ever since. And when I was coming out of university, I didn't know what I wanted to do in life. I really wanted to go into chemistry. That was always my plan. And because of treatment, I ended up with a memory recall disorder. I could not get through organic chemistry, which as nurses, you all understand.
Most of us can't get through organic chemistry, but for different reasons.
I did it 5 times before I was like, look, I know the material. It is just these tests and I'm never going to get there. And I had to, in my 5th year at university, switch majors. And I was chemistry, so I did everything that was kept my chemistry without any of the organic. So it's all inorganic stuff. I went into earth science and I don't care. Look, rocks are cool and I get it for people who love rocks. And I just don't care that much myself, but that's what I majored in. So I was like, I don't know what I'm going to do in my life. And that sense of uncertainty is what led me to my 2nd and 3rd suicide attempt. And I hate to keep bringing it up and to bring it down, but this position opened up at TCA and someone was like, hey, you've been advocating with us for so long. We think you might be a good fit. Like, do you want to come apply? And I was like, I don't know what I want to do in life. Like, sure, I'll apply to be an admin assistant and bookkeeper. That was 5 years ago. And every 6 months or so, I found a new thing that I took on. And now I don't do any of the admin and I don't do any of the bookkeeping. I get to sit on calls with hospitals, with healthcare teams, and help them figure out how to build programs for adolescents and young adults with cancer. I have found so many AYAs that are trying to give back, that are trying to make the experience just a little bit better for patients like them. And look, there's a whole group of patients who are like, I actually want to get as far from cancer as possible. And that is so valid. And there's so many of us that are trying to figure out what we can do to leverage our own experience, right? We are a population that has stayed connected to each other, whether that's social media or whatnot. And we live in stories. All of us as human beings, we live on stories. And how much does it mean to find somebody like you, to hear that story about someone like you? And I think giving back to that space and feeling confident, I now get to see the work I do help on a national level. And that's crazy. That's so cool. And I have so much gratitude for that.
That's wonderful. I'm struck by, as you shared your own history of moving even after treatment and getting through school and still grappling with the repercussions of what cancer did to your life and your plans. And I think that just to me emphasizes that we as nurses, even if we are firmly in the post-treatment survivorship phase, not letting our guard down as nurses to be asking those tough questions and probing and not just saying, hey, how you doing? And moving on. I think that's something that's for me a take home of those questions and those concerns and those challenges persist. Even when treatment's done, even if prognosis is great and everyone's, feeling good, as you've shared with us, those things are still very real for patients in that phase of their care. And so for us as the clinicians and the healthcare team, we just need to make sure that we acknowledge that even maybe what we consider as the air quotes, the hard part is over. Not all the hard parts are over, and there will be more to come, and they might come in waves and they might not be consistent or sequential. That's something I think for me as a nurse, staying vigilant and making sure that we're asking those questions to make sure we truly are supporting our patients with what they need, with where they are in their treatment journey.
I talk to a lot of patients and a lot of survivors, and everybody's story is unique and we all have very similar themes. And it is so common that treatment has a lot of structure. You kind of know what the plan is and it sucks. There's pain and nausea and fear, but you put your nose to the grindstone and there's a good guy, which is you, and a bad guy, which is cancer, and you just get through it. It's very clear. And you have so much attention and dedicated support. And then when treatment's over, everybody pats your back, dusts their shoulders, and says, congrats, go get out there. And all that structure goes away. And you are left floundering, trying to reconnect to what you were before and what life looked like. And it's not always the same. And I'm going to say most, although it's probably a lot. And I'm going to say most patients, AYA patients would say treatment was the easy part. And those first 2 years after treatment was the hardest part of cancer. That reintegrating into life, that trying to contend with what just happened when you're no longer in survival mode.
Wow. That's powerful. That's powerful. And I think it comes back to, we know in nursing, our roles for nurses are continuing to evolve and develop, which is what makes this such a great career. And the notion of nurse navigators and kind of where they're living in the space of cancer care, they're living across the continuum. And so, this to me highlights the critical importance of making sure you have navigation positioned in survivorship, because the needs, the referrals, the assessments that need to be done to make sure that we're still providing the right support and the right guidance in that time of the care continuum. Again, it's certainly not intentionally overlooked, but as you said, I think from the clinician standpoint, when we're looking at lab results and the treatment doses and all of the very, very granular pieces of that puzzle, when we get past that, we have a different perspective. And you as the patient, it's the opposite, because then now you're the ones stuck with dealing with the details of your life. I think this is just very powerful to hear and to consider, we as nurses, as we take this back to our own practice, where does this live with us? And how do we implement some changes to make sure that we're providing the right support at the right time?
What a lovely lead in to talk about Teen Cancer America. And just to say, that is our goal at Teen Cancer America. We are not a patient-facing organization. We are a hospital-facing organization. We're here to help support you all. And it has given me so much as a survivor to understand my own experience, but also to say, look, doctors, very good at being doctors. Nurses, very good at being nurses. But you all were trained to be doctors and nurses. You weren't trained on program development. And that's not to say that you all don't do it or aren't asked to do it. We know that you are. And so that's why we at Teen Cancer America really want to be your support system in that. We are totally free. Anything that you do with us is free of charge for you or the hospital. And we help walk you through in a non-prescriptive conceptual framework, which is all to say that we don't tell you, start here, do this, do that. No, every health system in the US is different because we don't have that national healthcare system. So we work with you one-on-one with your institution to figure out what makes sense for building out these programs to provide comprehensive AYA cancer care. It is such an important piece in coordinating this care between peds and adult oncology. And I say program, and that could mean a million things. So I'll be a little bit more specific and to say, we want you to think through that clinical care and environment. Are patients being treated with the right protocols, this or that? The same patient, 20 years old, diagnosed with leukemia, treated in peds versus adult, the peds protocols have about 25% better outcomes than the adult protocols. Same patient. It's just they walked in through a different door. It's the opposite in breast and colorectal. And we're seeing these patient ages getting younger and younger and younger. If you have a 15-year-old diagnosed with colorectal cancer, they're probably going to be treated in the adult side. And what does it mean for the support for that patient? Thinking about clinical trials, again, the sitting between peds and adult makes it so that there are so many less trials that they are going to be allowed to be enrolled in. A pediatric trial for a 19-year-old patient in peds may be closed to them because they're not 18. Psychosocial support, survivorship care. What is long-term survivorship? I don't mean to throw shade at our older cancer patients, but they're not living 50 years after their treatment. So there's a whole set of side effects and issues that are coming out. The latest information that we're seeing is that the comorbidities for AYA patients really start to peak at 15, 20 years after treatment. So for that 80-year-old, maybe they're having the same issues, but they have a lot more other things to contend with at that time. An AYA patient may have another 50 years of life after that. So what does that mean for that patient? Like you're talking about, how does survivorship work for that? What is sexual health, fertility? What is palliative care? These palliative care departments are probably desperate to get to your patients earlier. What does end-of-life care look for a patient who hasn't gotten a chance to live their whole lives? It's really important stuff, and that is too much to ask of any one person to figure out. And so Teen Cancer America wants to provide some of that framework, and we are by no means the be-all, end-all, know-it-all. We don't have a TCA way of doing it. We want to work with you to figure it out. And we have hospitals around the country that we work with, and we want to leverage to your success. We are big proponents of the beg, borrow, and steal, Let's take the model that this hospital has and see how we can adapt it to you. Oh, you want to, you're talking about navigation. There's these new reimbursements that are set up and we're still figuring it all out exactly. But okay, that hospital's doing it really well. You want to figure it out? Let me connect you with them. Like, we are not jealous lovers by any means. We want you to take our network, take our resources. I always use this metaphor, which is that patient care, especially in cancer, like you're saying, is a village, and it takes a whole group of people, and people fall through the cracks. So the more that we can provide these connections with one another, we're like a net. And so the more connections we have, the more knots we tie, and the tighter that net is, and we catch more people in our safety net. And so I really want to promote this sense of collaboration. And AYA Oncology has been so collaborative in a space where healthcare can sometimes be a little competitive between institutions. But we don't want that. And we have a bunch of spaces for clinicians to connect, and we want to connect. And my bait for you is, again, our work with you is all free. And if you finish our work, you can apply to us for a grant, and we provide seed funding for positions. We know that work happens because people do work. And so we provide positions. Navigators are one of our most funded positions. We just want to help you help AYAs. We don't work with patients directly, so your success is literally our success.
So let's talk a little bit more about just how Teen Cancer America and other organizations function really in that advocacy space. What do you see as the role of both your organization and others in advocating for AYA cancer patient needs, and just more maybe on that national scale? What are the needs of advocacy, and what are some of the initiatives that you see right now on that landscape?
I mean, I've done my little elevator pitch for TCA now. We went down quite a few floors to give me the time to go through all that. But advocacy organizations are there to support you all. Like we said earlier, the reality is that healthcare is overburdened right now. We're seeing an all-time low for staffing, an all-time high for patients, and we are asking clinicians to do more things. Oncology makes a lot of money. And the reality is that it also costs a lot of money. And a lot of oncology centers are, for better or worse, not doing great financially. And that means that a lot of the support that you all had and the additional staffing isn't coming to play. And that's kind of a bleak way to look at it. And I sometimes get in trouble for being a little too candid. But it's to say that there is a lot of really good work being done in the nonprofit space. And a lot of times they don't have to deal with the same kind of red tape that you all do. HIPAA is really important for protecting your patients. It also makes it really hard for them to connect to people. It's not the case in nonprofits. One of my favorite examples is we have a hospital we work with that provides no social programming for their patients. They have a good nonprofit in the area that does it. And so they say, we're not going to use our people, our capacity to do that. It takes time to plan an event or a meetup or a support group. And they just don't do it. They don't have the time, but they have a good nonprofit that they reach out to. So they tell their patients, here, go talk to this group. They're doing really good work. If you have a patient, if your hospital doesn't have a lot of financial navigators for your patients or insurance, people to help them navigate insurance or legal issues, send them to Triage Cancer. They're a great national nonprofit that does that specifically. They want support groups. There are hundreds of organizations. Peer-to-peer is one of those initiatives. Peer-to-peer mentoring is one of those initiatives we see hospitals try and never be able to get through the HIPAA piece. So send them to Immerman's Angels. They do it every day, all the time. That's what they do. So there are really good nonprofits that are there to support you. If your hospital can't do something, find a nonprofit that does. Your patients need this care. They absolutely do. And you all don't always have the time to provide every piece of the puzzle. And that's okay. Give yourselves permission to say, that's just outside my capacity. Nurses work a 12-hour shift. You can't fit everything you do in 12 hours anyway, much less to be a social worker and a therapist and a friend. It's a lot. And I want to give you permission to say there are other people doing that work and they want more people to come to them anyway. That's a win-win.
As you said, from an efficiency standpoint, if someone else is doing it and doing it well, does it even make sense to try to replicate it? Or do you just capitalize on the great work and the foundations that have already been laid by those organizations? I think you bring up great points, especially knowing when you think of the business of healthcare, there has to be a volume that justifies the investment. And so while the AYA population of patients with cancer is certainly unique, and we've explored a lot of those themes today, the business-minded people in healthcare might say, well, yeah, but that's not a majority of our patients. So, I mean, I think you bring up great points of ways to address that and acknowledge that there are financial limitations in healthcare institutions, depending on the size, depending on how they're building their budget and what they're placing kind of their priorities on. And so it is important, I think, for any organization to understand what else is out there, whether it's a local organization, a national organization. I mean, so much now is done online anyways. I mean, I don't think that we have the same physical limitations that we once did. And so just being curious and trying to explore those opportunities and sharing them, once you've reviewed them, vetted them a little bit, being able to share them with your patients. So you might not have the answer yourself, but you do have options for the patient to explore. And so I think that's a really important angle for nurses to consider of how they can influence this work. If they themselves cannot or are not able to dedicate the time to creating these programs themselves, who can help? And as you said, Teen Cancer America is one of the many organizations that can provide that help.
And we have lists of nonprofits. So if you're like, hey, I need a support group organization, but I don't have the time to go look for it, reach out to us. We'll send you a bunch.
So kind of a final question before we move into our wrap up. So if nurses are listening and they are energized and they're like, I want to get involved, I want to help in this advocacy space, in this supportive space for AYAs, what can they do? What would be their first step to try to get involved in this type of work, whether it's through Teen Cancer America or other organizations?
My first pitch will always be come talk to us. Come talk to Teen Cancer America. We'll help you with all of that and get you connected to other spaces that help you figure out what that looks like at your institution. Again, every hospital works a little different. You have different limitations and restrictions. Teen Cancer America has a group we lovingly call everyone but the docs. It's all the nurses, social workers, supportive healthcare, all of that piece. And it's a very collaborative group. We have a monthly discussion-based call, and we have an online forum where people share resources, ask questions, have discussions about AYA activities. And it is so easy to use and to be a part of. We also have a monthly webinar called the Monthly Drip, where oncologists and researchers share the kind of the latest and greatest in AYA care. And we also look at different models of cancer care. But I think the number one thing that you can do at your institution is to start finding other people who care at your hospital. Get together a working group, a little team of people who say, I know we can do better. I know we can do better with our patients, and start to look through what does that mean to standardize something a little bit more structured. Because again, nurses, all healthcare professionals really are overburdened right now. I mean, and will always be. So what are the things that you can put in place at your hospital to help support your work so it's not a bigger load to provide better care? What is a patient needs assessment that you can use, that you can hand to patients so that they have a more structured way of asking for help? What is a referral pathway that we can automate so that when an AYA patient enters the system, it automatically triggers fertility or automatically notifies your social worker to give them access to these resources, right? What are those pieces in play that you all can put in the front load of effort to do to help ease that work later on?
And I think you just highlighted just the importance of how to eat an elephant, one bite at a time, right? And so sometimes those bites can be really small, but still really impactful. And so, instead of thinking that, to better serve our AYA population, we need some $1 million funded project that has somebody's name on it. It doesn't have to be that. No, but that would be great if it was.
Oh, we love that.
It can't always be that, right? We know it will never always be that. And so I love your recommendation of nurses getting together with like-minded clinicians who have an interest, a passion for how we can do this better for our AYA patient population, and then finding those incremental wins that still can be hard. I mean, anything you want to change in the electronic health record, it takes a mountain has to move to get that done, but it can get done. And so I think you've just brought some great ideas forward of just how, yes, we want a big monumental shift, but sometimes that comes through those small incremental changes.
Healthcare takes forever to change. Let's be honest about it. It's not a quick adjusting field, and that is okay. You kind of build those steps, and all of a sudden administration's like, actually, this is a new priority for us, and you strike while the iron's hot, and things happen really quick. Yeah, as soon as you can get the EMR system figured out, let me know. I would love to have a quick talk about how to fix that quickly.
Absolutely. Well, Alec, thank you so much. I appreciate and so value your candor and your honesty and just kind of giving us a peek from your perspective of how the work we do as nurses was impactful for you as you were going through your treatment and diagnosis, and then how it influences the work you do now as part of Teen Cancer America. So I really appreciate you sharing all of that information with us and with our listeners today. As we move into the end of our episode, we like to kind of run through a quick fire series of questions just to help summarize some of the major themes that we've talked about. So to start that off, first question is, how can healthcare professionals evaluate their hidden or implicit bias about the unique needs of AYA cancer survivors?
The first one, just like every implicit bias conversation, is just acknowledging that there is an implicit bias and working actively to address it. I think it can be really helpful to even look at a patient needs assessment. There's one called NASB that's developed specifically for AYA, just to be familiar with the kinds of things that are specific to adolescents and young adults that can be an issue. I think education is your greatest tool.
What are some common misconceptions about the needs for AYA cancer survivors?
That they're the same as other age ranges. And then the other one I want to call out is, we talked about it, but that early survivorship time. Cancer's not over when treatment is done. Cancer is a lifelong commitment, so to speak. It's a club none of us wanted to be a part of, but we are now, and acknowledging that a lot of these issues come up in survivorship rather than in treatment.
What's something about this topic that's not often discussed, but you wish people knew more about?
I'm going to send people back to Teen Cancer America, nonprofits, and just really allowing nurses to say that there is going to be stuff that I don't know, and that isn't a failing on my part. Saying I don't know something helps my patient have more confidence in me. I hear all the time clinicians who are like, I don't bring up sexual health because I don't know what to say and I don't want them to lose confidence in me. They don't lose confidence in you because you don't know something. You're a human also. They lose confidence in you when you stop caring about them.
What additional training or education do oncology nurses need to stay current in this topic?
Listen to this podcast. Come to Teen Cancer America. We have the monthly drip. We have this program advisory groups. There's a national organization right now called the AYA Cancer Coalition. Join that group. They're doing excellent work. If you can, there are regional conferences. There are virtual symposiums. There is a global AYA Cancer Congress that's hosted about every 18 months. So for those of you that have the funds to go to Australia this year, it's in early December. It'll be in the UK next year. It was just in Long Beach last year. So there are a lot of conferences to attend as well.
And finally, what are some additional resources for patients or maybe other clinicians, non-nurses who want to learn more?
Stupid Cancer has a set of resource guides on their website for patients broken down by category. I think it's really helpful to peruse some of those. For providers, you can look at them as well. Learning from them is really important. I'm also going to shout out Elephants in Tea, which is a nonprofit and a magazine. They will send AYA magazines written by patients for patients. There's other perspectives, but it's really those human stories. They'll send them to the hospital. You can just connect with them, send them to your patients, but it's ways for patients and providers to feel connected and to understand the AYA experience and the AYA voice.
That's amazing. And we will certainly try to link as many of those things you've mentioned in our episode notes. We'll try to link as many as we can. Well, Alec, thank you again. It's been a joy. I've really enjoyed talking with you, and I appreciate all the information that you've shared with our listeners today. Do you have any final comments?
My big final comment is thank you to nurses. It is not an easy job. And I know you all do it because you want to give back and you want to be there for your patients and to help people. And the reality is not all patients are willing to accept that. And you have hard jobs, whether that's the time that it takes, the amount of effort, the amount of stress. It's tough. And I don't envy you, but I'm so grateful for the work that nurses do. Please let us support you in whatever way we can. Come to Teen Cancer America. Come to me personally. Look at any of these nonprofits. We want to be your support system because you're putting in good work and hard work, and it sucks sometimes. So let's try and take just a little bit off your plate because you got pretty full plates.
Well, thank you so much, Alec.
Thank you, Jamie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.